No, do you
Hello,
want
everyone. Thank you so much for joining us this morning, afternoon. This is a webinar on the DRTB Care Package implementation at facility and community levels. This is a series of webinars that URC is presenting along with USAID on TB Care 2. We have quite a few more webinars that we'll share the dates for at the end, but I'd love to pass it on to Lisa and Darcy, who are the lead presenters.
Thank you very much, Sharanya. And can I just remind everyone and ask Sharanya to mute everyone's microphones so we don't have any background noise as we go?
Yes.
Thanks. It's wonderful to have all of you here. My name is Darcy Richardson. I was the lead consultant on this project to pilot a comprehensive approach to patient care for people with drug-resistant TB. And we're going to talk about how do you actually implement supportive care at a facility level or community level? So what happens on the ground through the framework that we developed for this project? Could I have the next slide, please, Sharanya? I'm here with my colleagues, Lisa Adams. Dr. Lisa Adams was the epidemiologist on this project as part of the core team. And then we have our colleagues from Ukraine and South Africa to talk about how this really happens on the ground. So I want to give most of the time to them, and I'm just going to present a little bit of a background review of what the framework looks like for comprehensive supportive care for people with drug-resistant TB. Lisa's going to talk about how do you measure this and determine how much progress you've made in this regard. And then Svetlana Okromeshko and Princess Rapolo are going to talk about steps in planning implementation at the facility and community levels and how they did it in Ukraine and South Africa. We're going to provide some resources for you, and then we'll hopefully have plenty of time for questions and answers. Slide, please. So I want to make everyone aware that there is now, the guidance document has been published. It's online. You can download it at the address on the bottom of this slide for free. And there are two parts to this document. First is what I call the practical guide. It's a short introduction to delivering comprehensive supportive care to people with drug-resistant tuberculosis. It's meant for everyone who comes in contact with people with drug-resistant TB and try to support them in any way. And it provides the overall description of the framework that we use to actually implement a comprehensive care package. And then the second part of the toolkit includes all of the tools and templates you would need to help you plan this in your country at a facility level, at a national level, and down to the patient care level. So there are instructions, there are 14 or 13 elements of supportive care, and we have created 2-page how-to guides for each one that goes through the rationale for that particular element of care, what some of the evidence is for implementing that element of care, and where you can find additional resources, and then some success stories. You have a lot of templates and tools to actually plan at your in your country or at your facility. So that's an important resource for you to know about. And as I said, feel free to access that anytime. I would encourage all of you to download that and refer to it as you need to. Next slide, please. So this is just a refresher of what the comprehensive supportive care framework looks like. When we look at the literature and think about where we are in terms of global TB success, global treatment success for people with drug-resistant TB, we're only a little over 50% treatment success. So clearly things need to be done. And what we find when we look at what's happening in many countries is that it's not only coverage with diagnostics and with drugs, it's also how do you support patients through treatment, because it's a very rigorous and difficult treatment. Even short-term regimens aren't that short. And so we need to implement other elements of care, some ancillary elements that will help support people as they move to cure. So what we've done is created a framework. There are 4 thematic areas in that framework, and under each there are specific elements of care. So the thematic areas are respect for autonomy and support for self-efficacy, so that entails helping people engage in decision-making about their own care and providing them with services that are convenient to them. The second thematic area is maximizing their physical comfort and safety, so that's all of the things around monitoring for side effects, treating them for comorbid conditions, helping with their own nutrition, etc. The third area is providing psycho-emotional support and protection from isolation or discrimination. That includes all of those elements that would be supportive in the community, thinking about how people interact at workplaces, in communities with their families, and connecting them with peers to help provide support. And then the final area is preventing catastrophic cost to patients and families, and that's about both direct and indirect financial assistance. So you can hit the next 4 down slides, I think. Sure, on that. Or 5. Yeah, 1 more. There we go. Okay. No, go back. Yeah. So these are the 13 comprehensive care elements. So under each of these thematic areas, we have specific areas or elements that we call them to think about covering when you think about providing comprehensive care. So first one, and a very important one that Svetlana and Princess will talk about, is patient assessment and care plans. So that's actually sitting down with a patient, assessing what that person needs or wants at the very beginning of treatment, and then monitoring that throughout treatment to see how things change, and making sure that the care plan and the supportive care they're getting is what they need and want. Education and treatment literacy, and then treatment at location of choice, whatever is feasible within the constraints of the health system. Then under physical comfort and safety, we have the monitoring and treatment of side effects, nutritional support for the patient himself or herself to make sure that they're responding well to treatment, monitoring and treatment of comorbid conditions like HIV or diabetes or other things that might interfere with their cure, physical rehabilitation after cure in the case of people who have experienced side effects that are lasting, like hearing loss, and then providing palliative and end-of-life care for people who cannot be cured. So then we move on to psycho-emotional support, and under that we have 4 different elements. First is respectful, compassionate communication, and we're really talking about between providers and patients. Monitoring and treatment of mental illness, especially depression, which often affects people who have multi-drug tuberculosis. Addressing social isolation and the need for emotional support through creating peer groups, one-on-one counseling, etc., and protection from discrimination and stigma through legal means and through education and outreach to the community. And Princess is going to talk a little bit about that element and how they implemented it in South Africa. And then finally, under catastrophic costs, it's financial assistance, and that could be direct financial assistance like cash transfers to patients, or it could be indirect financial support like providing food baskets or vouchers or transportation to patients and their families. So when we think about providing supportive care, what we have done in our pilot countries, and the nice thing about this framework is it's very adaptable. So you decide what's most important to implement in your country. You start with the priority elements and think about how you can implement them in your particular setting. So it's a very flexible framework that can be adapted to any kind of setting and any kind of facility setting, because we know they're different from one place to another within the country. Next slide, please. Sharanya, can I have the next slide? Thanks. Okay, so this is what we're talking about when we say we're going to operationalize this framework or this care practice. At the global level, we've created the framework that you just saw. Then at the national level, you assess what you're doing right now, because every country is already working on some of these things. And where do you have gaps? And then thinking about how you're going to fill those, what's important for you in terms of where are you with treatment success for drug-resistant TB? What else might you cover to improve that treatment success? And so then you create this generic package at the national level. That's the idea. And then when you get down to the local or facility level, which is what we're talking about today, how do you adapt that package to your own local circumstances? So if you're working in an urban area, your package might look slightly different than in a rural area. Or if you're working with a specific population of people who inject drugs or migrants or other populations that need specific services, you might tailor your care package. So that's what we're going to talk about today is what do you do at the facility level to implement this framework, and how do you establish those clear roles and responsibilities, and what has been some of our experience, and what advice can we give you in terms of how to do this at a facility level or a local level. And then it gets down to the patient level, which is where you implement the care plan. Next slide. So I just want to briefly say that when we're talking about comprehensive supportive care, this is only one element of how I would define quality care for people with drug-resistant TB, which starts from prevention, by making sure that people with drug-sensitive TB complete treatment, to infection control, contact investigation, implementing rapid diagnostics, having well-trained clinicians and health workers, drugs, monitoring for side effects, and ongoing monitoring following cure. So we're really concentrating on the supportive care element of an overall package of quality care. Next slide. We're really going to focus on these 4 steps in implementation at a local level today. And the first one is identifying and orienting your own local stakeholders. So you need buy-in from the people who are going to be implementing this and making decisions about allocating resources for a supportive care package. And that's the first step in the process at any level, whether it be national or down to your facility or community level. Then you develop a facility-specific plan for implementation. You have to prepare your staff in the community and at the facility for being able to provide the services that you have decided to implement, and then monitoring your progress on at least a quarterly basis to see what's working, what's changing, and what else can you do to improve your performance. And that has been really critical in the pilot countries that we've worked in. Next slide, please. So I'm going to turn this over to Lisa Adams to talk about what we did to evaluate this package down to the facility level, and then we're going to hear from our country colleagues. Lisa.
Thank you, Darcy, and good day, good evening to everyone who's on this webinar. I'm just going to give you a quick overview of what we did to help assess the DRTB package, because we all know that what we really want to know is what impact is this care package having on our patients and the healthcare workers and really the healthcare system overall. So I want to just give you a little bit of background, and so it'll help help you understand when our country presenters are talking about some of the results. So we wanted to assess really 3 things. How this was affecting patients. Were they happier, more satisfied with the care they received? Were the services meeting their needs? And secondly, was this feasible and acceptable to the frontline healthcare workers and upper-level healthcare managers? Was this going to be a sustainable model? And then thirdly, of course, what was the impact on patients' clinical outcomes? Were actually more patients being cured under the supportive care package? So in terms of patient satisfaction, obviously, we surveyed patients, and we did this by first surveying a cohort of patients before they received care under the package, or using a control group of patients receiving care at a similar facility, but without the care, where the care package was not being implemented. And then we compared those results to patients who had been receiving the care package for at least 6 months to see if they felt that their care was improved, and they rated their care more highly when they were receiving it under the care package. And then secondly, we surveyed healthcare providers and managers, again, asking them if this was a feasible, acceptable, sustainable model, and what did it do to their job satisfaction, and what kinds of maybe secondary rewards or gains were they noticing by implementing and providing care through the care package. Next slide, please. And then, of course, as I mentioned, it's really the treatment outcomes. We want to, the ultimate goal is to have more patients cured, or improve that cure rate that Darcy mentioned is just unacceptably low at about 50%. So for this assessment, what we did is we looked at historical outcomes data, usually programmatic data, and then compared it to the results of patients who had been receiving care through the care package. However, the pilot was really only implemented for 6 to 9 months. So for most patients, we didn't have final treatment outcomes. So we had to use interim outcomes. And you'll see that mentioned when our country partners are presenting their data. So the interim results that we looked at and what we hoped to see was that a higher proportion of patients had either completed or were still on treatment after 6 to 9 months of receiving care under the care package. Because South Africa was implementing the short course, or had started rolling out the short course, we did actually have some patients there who had completed treatment. But in most cases, we were looking at still on treatment as a proxy for likely to be able to complete treatment. And we hope to see, of course, a lower proportion of patients who died during treatment and a lower proportion of those who were lost to follow-up. And again, that higher treatment success rate is the ultimate goal, and that was being determined post-pilot. So you will see some of those data presented as well, as our country partners have been able to follow some of the initial pilot cohort through to completion of treatment. Next slide, please. And so with that, I'm going to turn it over to our in-country partners, and they're really the ones who are the frontline team on the ground doing the implementation. And so first, we're going to hear about the experience at several sites in Ukraine. So I'll turn it over to Svetlana.
Hello, good morning, good day, everybody. My name is Svetlana Okromeshko, and I work as a consultant for PATH and for Challenge TB project, including this pilot. And I will talk about our experience in Ukraine. Of course, we went through all the process that Darcy just described, but because of shortage of time, I will specifically focus on organizing multidisciplinary team in Ukraine. So in Ukraine, supportive services for DRTB are currently funded by USAID Challenge TB mechanism that is implemented by PATH since 2015. No, previous slide, please, previous. Can I have, yes, please. A global fund. So most MDR-TB treatment failures and defaults occur at the ambulatory phase, especially among patients at risk, HIV-infected, homeless, alcohol or drug addicts, ex-prisoners, unemployed, and others. So we are prioritized for supportive services those who are at risk to improve their treatment adherence and their chances of cure. The most suitable model to organize this treatment process of patients with a wide range of problems and lack of motivation for treatment is a multidisciplinary team, one of which you can see at this slide. So this team approach helps to link TB services, primary healthcare, social support provided by NGOs in Ukraine, with other services to ensure that DRTB patients get the help they need to complete their treatment. Now, next slide, please. Next slide. Yes, thank you. To make the best use of available funds under the Challenge TB project, PATH and its partners developed the strategy of social and psychosocial support for patients with DRTB. So you can see this orange book. This is the strategy, and underneath this is the algorithm that we developed. So the goal of the strategy was to lay out the common vision regarding the provision of social and psychosocial support for DRTB patients, to build suitable adherence to treatment, to promote effective planning, implementation, monitoring, and evaluation of psychosocial support, facilitate partnership and coordinated efforts of all the partners, as well as efficient use of resources. The strategy is based on the patient-centered and team approach and creation of multidisciplinary teams. First, project partners conducted a thorough barrier analysis about social, psychosocial, legal, and other problems that cause treatment defaults, and all the involved partners, meaning TB doctors, primary healthcare providers, and social workers, agreed on algorithm and their roles of providing supportive services. According to this algorithm that you see on the slide, before discharging from the hospital, the attending TB doctor and the patient meet the social worker from the NGO, and they discuss and select optimal model for ambulatory treatment that is close to the patient home in a convenient location. Then this patient is assigned to a specific multidisciplinary team that is led by his TB doctor. Since in Ukraine the healthcare system is vertical, every patient at the ambulatory phase of treatment, no matter what model he has chosen, remains under the supervision of the Rayon TB doctor. Rayon in Ukraine meaning province. Family doctor only organizes the treatment at the ambulatory phase according to the TB doctor recommendation. So the key members of the multidisciplinary team are TB doctor, DOTCOR supervisor, and social workers. And then other professionals that join the team according to the needs of the specific patient. MDT, multidisciplinary teams, are created on the basis of an order of the Oblast Public Health Administration. This strategy has been implemented by PATH since 2015 in 6 oblasts of Ukraine, and more than 170 multidisciplinary teams were created. When this pilot started, the comprehensive care package, since PATH intervention already included many of the services, the Ukraine pilot added the missing part, which is inpatient component in the hospital. Before that, we worked only at the outpatient ambulatory phase. So this pilot ran from October 1st, 2017 to March 2018, 6 months. All involved partners agreed to use the patient assessment and individual care plan tool, the one that was mentioned by Darcy before, when a patient is admitted to the hospital. This tool was used for better understanding patient needs at the beginning of treatment and to develop an individualized plan of care. In the pilot, the results of using these tools were being incorporated into the patient record and transferred with other paperwork to the outpatient clinician upon patient's discharge from the hospital. Next slide, please. Next slide. At this slide, you see the steps that are required for the implementation of this supportive care package, including preparation of orders of Oblast Health Administration, which is a very important step for Ukraine since the vertical system of healthcare, conducting a variety of tailored training for hospital staff, local NGOs, multidisciplinary teams related on patient-centered approach, regular monitoring visits, and others. Next slide, please. As previously mentioned, when the RTB patient is discharged from the hospital, he is assigned to a specific multidisciplinary team led by TB doctor. One specialist alone cannot solve all the problems of the patient. It is necessary to unite the efforts of many professionals whose assistance is required by individual needs of the patient. So when a patient is placed at the center of this circle, both medical and psychosocial care, which is multidisciplinary team, he is seen not just as a service recipient, but as a rightful partner who can make informed decisions. Multidisciplinary team goal is to reduce treatment defaults, build strong adherence to the treatment, and retain patient on treatment until its full completion by providing comprehensive medical, social, and psychosocial patient-centered support. Next slide, please. At this slide, you can see the basic structure of multidisciplinary team. The team is led by a RIAN or district TB specialist who determines, TB doctor, who determines case management tactics and is responsible for the treatment of the result. Key team members are also DOT supervisor, social worker, and you can see how DOT curator or supervisor are connected between, because they need to communicate on daily basis as they help, a social worker help DOT supervisor to assure that patient takes pills every day, and if it misses the dose, social worker helps to find that patient. Also, the team includes a lawyer, psychologist, and other specialists in particular fields based on the specific needs of the patients. On the top of the structure, you can see on the right side, coordinator from TB service. This is very important in our case. It is very important player. Since this is the person who is appointed by in each oblast by TB service, and this person is responsible for referring DRTB patient at risk from the hospital to NGO for supportive services. And this person maintains an integrated list of all DRTB patients who receive support, so we can avoid duplication. Also, he is responsible for monitoring and verification treatment results in the registry. So each multidisciplinary team works very closely with this coordinator and also with the project coordinator from the NGO who provides social support. Next slide, please. This slide lists the functions of MDT. As I previously mentioned, when the patient is admitted to the hospital, their needs are assessed by the hospital staff. Then social worker, when the patient is at the outpatient stage, again conducts this assessment because needs are changing, and then it is done also periodically throughout the course of the treatment. Also, the function of multidisciplinary team includes comprehensive analysis of patient's health status, provision of treatment throughout the course of the outpatient stage, detection and timely management of side effect, and providing a wide range of psychosocial services based on patient needs. Next slide, please. These are requirements for effective work of multidisciplinary team, and I want to specifically emphasize the importance of active interaction of multidisciplinary team with the TB service coordinator whom I mentioned above. Since we need to track, to monitor the status of treatment and the impact of the treatment. Next slide, please. These are the results of our work. You can see at this slide the comparison of the two groups. The first line is those who received standard care, the next slide, those who received the supportive services. And you can see the difference in treatment success rate. Those who received comprehensive care, 77%, and the standard care, 46%. Next slide, please. Throughout this process, we of course have many challenges. For example, some hospital workers could not understand how to use this patient assessment and individual care plan tool. They thought it's too long. They didn't know who needs to fill it out and how to do it. So it was very important to do meetings to actually adapt this tool to each facility and also train staff before doing this pilot, so they know exactly who, when, and how to do it and how to use the result. Next slide, please. The last two slides actually list the success factors that, in our opinion, are very important to take into consideration when do this work. The time is very limited, so I won't list everything, but I would just emphasize the importance of individual approach and doing assessment, needs assessment of each patient and why this patient can be lost to follow up, and address those reasons, address those needs. Also, clear understanding and agreement of approach of using algorithm, of providing supportive services, and then effective implementation and following this algorithm. Training all staff before you start providing those services, and providing periodical meetings to review challenges, to share experience, and actually to refresh training. Next slide, please. Also, very important, the commitment and leadership of TB service. Since all the work that we did was to support them so we have better treatment results. And of course, there is a lot of other information that I would like to share, and I hope you will have some questions that I can respond later on. So now I will ask Princess to join us and to explain their experience in South Africa. Thank you.
Good afternoon, good morning, everyone. My name is Princess from South Africa, and I'm going to present our experience of implementing the supportive care package. Next slide, please. Next slide, please. Thank you. In South Africa, the supportive care package was piloted and implemented in 3 provinces, the Eastern Cape, Free State, and Limpopo. 225 patients were enrolled in the pilot. And as you can see, this is a breakdown of the facilities where the pilot was implemented, as well as the number of patients that were receiving the supportive care package in these specific facilities. Next slide, please. So as part of our essential elements, we elected to have 7 of them, and they focused on patient and family education, monitoring of side effects, monitoring of mental health, nutritional support, psychosocial support, protection from stigma and social isolation, as well as economic assistance through social grants. Next slide, please. Next slide. So our model of care that we use in the country is that of decentralization, and it assists in placing the patient at the center of care starting with your primary healthcare facilities up to the specialized centralized units. And we also have another level of community-based support, where then we see that patient-centered care approach, where you have community health workers who are supporting patients, and we also have family and stakeholder support on the other side. Next slide, please. We also had our multidisciplinary teams, and these are the stakeholders that formed part of our multidisciplinary teams, and it was important for us to get buy-in so that we can introduce the pilot as well as talk about the service package. And next slide, please. So our critical next steps after we conducted our roadshows and we recruited our patient, it was important to provide capacity building for core team members, and especially those who were working very close with patients, social workers, nurse coordinators, as well as community health workers. The training that we provided was basic TB training, and it covered topics such as, the basics of TB disease, how it is transmitted, the importance of taking treatment, issues of side effects, as well as concepts about adhering to treatment. And this was done so that the same team members will be able to translate that training into the patients and family members through TB education and the importance of TB adherence. We also conducted nutrition training. And as we are aware that, when it comes to TB and DRTB, nutrition is very critical. And you find that many of our patients are malnutritioned or malnourished because of issues of poverty and of food insecurity. So with nutrition training, we provided the skills to the health workers so that they can educate patients on the cost-effective means, of finding healthier foods that are sort of cheaper. And we also assisted and educated and guided our patients to start with vegetable gardening. We also conducted interpersonal communication and counseling, and this was critical in ensuring that our health workers are able to communicate adequately and effectively with patients so that our patients can really understand and receive the necessary counseling, and also for our health workers to be able to look at the practicalities that patients have to contend with, and when it comes to adhering to treatment, and to assist those patients to look at other ways that they can continue taking their treatment up to completion. We also did an orientation on conducting household risk assessments, and that looked at issues of infection control in the homes and making sure that contacts of TB patients are screened and educated on TB as well. Next slide, please. So these are the tools that we developed for the supportive care package. The quality of care assessment. It's sort of a questionnaire where the social worker or the team would go in, interview the patients, assess them, and identify gaps in care. And then they would also address those gaps through providing different services. We also developed the patient file or patient chart review tool. And this assisted in looking at the completeness. So this tool assisted in reviewing and looking at the completeness of patient files. We also had the household infection prevention risk assessment checklist, where we looked at issues of contact management, issues of prevention, of TB prevention, and issues of risk in the household. Next slide, please. So one of the key challenges that DRTB patients have to contend with is that of stigma. And one of the interventions that we did in a pilot sites were community dialogues, which were implemented by community members with the support of our health workers to engage with community members and patients to look at ways in which patients can be supported better to address issues of stigma and discrimination. And what was also important were local leaders within the communities participated in these dialogues. Over and above that, we partnered with 3 community radio stations in our areas where we took our thematic areas, we also took our essential elements and looked at content that was used to present and educate patients on DRTB and all issues about the service package. And an important part of this was that when we did our community radio slots or education slots, there were also presentations by former patients who were on DRTB who spoke about their experiences and shared their treatment journey. So as you can see, one of the other things that Matlala Hospital did in Limpopo was a community dialogue that involved patients, their family members, as well as health workers, to look at ways in which patients can be better supported and to appreciate that there are also issues of stigmatization and discrimination within health facilities. So there we have a picture of the social worker during a radio session. We also have a picture of a TB patient, a former TB patient sharing his experience. Next slide, please. So the role of social workers can never be underestimated. I mean, this is a cadre of health workers that went beyond and above to support patients. They assisted patients with applying for ID documents, assisted them to apply for social grants as well as food packages. We also had patients who were counseled, and some of the patients who were experiencing trauma about the diagnosis, anxieties, and depressions. So those patients were offered counseling by the social workers, and in areas where they needed further referral to a psychologist, that was also done. There we can see one of the nurse coordinators and patients tending to the vegetable garden. So all of this was done by the support and the intervention that was critical to supportive care and psychosocial care for patients. Next slide, please. So earlier we spoke about the tools that we developed to implement the supportive care package. So when we look at this tool, we bring back the chart review. So our DRTB nurses went through patient charts on a quarterly basis to identify gaps in care and to identify, what were the challenges, what were the issues. And based on the chart review, we begin to see that when we started at baseline, that is the blue bar, there were gaps with HIV testing, there were some issues in eye testing. Now I can see. Issues with eye testing as well as nutrition and adverse side effects, and nutrition we mentioned, diabetes testing as well. So the more we went in to assess these issues, to assess the patient files, recording improved. As you can see, 47 patients were referred for adverse side effects and 6 of them for ototoxicity. 70 health workers were also trained on nutrition assessment because that was one of the key gaps that we found in our sites. Next slide, please. So this is where the household risk assessment tool comes in. The tool assessed patient factors, focusing on contact TB screening and hygiene and infection control measures. And then under living condition factors, issues of ventilation and access to water and sanitation. So as part of our intervention, when we looked at this tool, implemented the tool, 581 household contacts were assessed. And 27 patients were found to have TB and were started on treatment. And with living condition factors, 6 family members whose conditions were found to be dire were relocated to new areas. The picture on the bottom of the screen that shows the before and after, that was the intervention of the social worker, whereby the social worker mobilized neighbors in the area. So this house is a house of a TB patient, and somehow down the line, people were just dumping their trash around the house. And the social worker came in, mobilized the community, mobilized neighbors as well, and they were able to get someone to sponsor those cedar bricks to build a fence around the patient's home. Next slide, please. So these are our outcomes. Earlier we mentioned that we had 3 pilot sites in the provinces, the 3 provinces. So we're presenting a picture. We're presenting a picture of interim outcomes for the Eastern Cape, particularly for the site where we implemented the package in Nelson Mandela Bay Metro. Alongside, we have a picture of another district where we didn't implement the supportive care package. And as we can see, with the supportive care package, treatment success was recorded at 78%. We do still have patients on the long regimen who are still in treatment. For the short regimen, they've all completed treatment. Now we do note that we have high mortalities for both the short and the long regimen treatment. One of the challenges that we've discussed, and one of the challenges that we acknowledge, and it cuts across the issue of patient education. We still have quite a number of patients who present late in facilities. And by the time they are in facilities or they arrive in facilities, they are quite ill. And it just complicates their treatment. We also noted that with our pilot participants, 60% of them were co-infected with HIV. So this is just a picture. We have not conducted a mortality audit, and we are sure that once we start conducting the audit, we will get a clearer picture of what were the issues that resulted in such high mortalities. Next slide, please. Lessons learned in summary, multidisciplinary teams are very essential in patient management. Conducting regular chart reviews improves quality of clinical care, and it serves to strengthen the health system. As we saw with the other slide, when we showed the baseline and the improvements in the subsequent quarters in terms of patient management, testing for HIV, assessing for nutrition and the like. So there is really a case for the service package and in conducting regular chart reviews. Next slide, please. Social workers were key, and they were patient advocates because they went in where patients were afraid to go in. They were able to have conversations with different stakeholders in areas where patients were themselves uncomfortable because of issues of stigma, discrimination, and whatever challenges that the patients were facing our social workers were able to maneuver and get in and provide the support for patients and provide the linkages for patients. Next slide, please. We would like to acknowledge the United States Agency for International Development. We thank our team, Dr. Alex, Lisa, Hilton, and Darcy. We appreciate the National Department of Health as well as our provincial departments that served as our pilot sites. We thank our multidisciplinary core teams as well as patients and their family members. Thank you.
Thank you very much to both of you for doing such a great job of presenting. And first of all, I just want to say that you all will, everybody listening will have access to all of these slides so that you can look at them a little more closely, because we didn't have very much time for them to cover all of the very hard work they did to make this project successful. Thank you both for the great presentation. We have a few questions, and if people have other questions, please feel free to go into the Q&A section and read your questions or in the chat if you prefer that. We have a couple of questions right now for Ivana. Raymond asked a question about how many patients a multidisciplinary team handles on a daily basis. You know, on average, how many patients is one MDT dealing with? And then overall, how many patients were in the pilot cohort in Ukraine?
I'm sorry, I have difficulties to some interruptions.
Oh, sorry.
So if I understood,
Yeah.
The question was how MDT works on the daily basis, how many patients are in the team?
So how many patients can the MDT team, does one MDT team deal with on a daily basis?
Okay.
In general.
It depends. It can be one patient, it can be 10 patients. It depends where patient was, what location patient selected for outpatient treatment.
Okay.
So there is one district or province TB doctor. So if the patient is referred to that doctor, he is under supervision of this doctor. It doesn't mean that this patient comes from the village to this doctor every day. No, they just decide who will be the dot coordinator. It could be a person like a nurse in the village or in a smaller town. And then social worker will work with this dot coordinator and also make sure that this patient once a month comes to TB doctor for observation, for the tests. And so in the team can be many patients. If there are like 7 patients, so there could be like 2 or 3 social workers. Each of them would have 2 or 3 patients to take care of. It could be a few dot coordinator. All depends on the location of the outpatient treatment.
Got it. Okay, great. Thank you. And how many patients were in the pilot cohort in Ukraine overall?
Overall, just a minute, I have this information here. So during inpatient treatment, it was 245, like in the hospital, and ambulatory outpatient, 419.
Yes. Okay, great. Thank you very much. Princess, there are a couple of questions for you. One is, who are the social workers? Are they nurses or could they be other types of people? And I think you have a specific cutter in South Africa, but maybe you can explain a little bit about who the social workers are in South
Africa. Social workers is a different cadre of health workers. They are professionally trained and they have a body that looks at their personal development, where they get their points and whatnot. So it's a separate cadre from the nurses.
Right.
The picture that we showed of someone tending the vegetable garden, that was the DRTB nurse. who supported patients as part of the supportive care package. And then with our patients, 2 of them were diagnosed with DRTB from the 27.
Right. So someone asked a question, just for those of you who are not looking at the chat. Out of the 27 household contacts who were diagnosed with tuberculosis, how many had MDR-TB? And the answer is 2. Thank you very much, Princess. And I think Dr. Kokar has his hand raised. Sharanya, if we can.
Yes, I'm unmuting you, Dr. Cooper.
Darcy, thank you very much for this. I'm really thankful to the Ukraine and South African team, which has put their best effort. Also thankful to Darcy, Alex, and Lisa for giving us so much information. My question is regarding the last 2 follow-up. South African team has shown 9% last 2 follow-up, and almost same is 8% in the Ukraine. My question is what step they have taken to bring those patients back, and what was the hurdle they faced?
Okay, that's a very good question. So to both Svetlana and Princess, the loss to follow-up, what are the challenges you face in keeping people on treatment, and how have you tried to address those challenges of loss to follow-up through the care package?
Ukraine.
Yes.
Thank you for this question. This is actually the key question, because the whole point of working of the team approach is to retain patient on treatment, to take it back if it's lost. And in Ukraine, I don't know, I try to emphasize that we focused on the patient with risk to be follow-up. Those patients who take drugs every day without our help, it's important to help them, but the priority was patients at risk. So we had really difficult patients. That is why coordination of this team, it's not just the formal team. This is actually the group of people who communicate on the daily basis. And social worker and coordinator are 2 very, very important team members. So social worker call nurse or vice versa every day. Did this person come and take drug? Yes. Then if not, then the social worker will visit or call the patient and look for them. And look at the number of different resources. So I can give you a specific example if you're interested. How they were returned back. So it's a very difficult job, and it's unfortunately not everybody. We had some people whom we lost to follow up. However, the number decreased completely and dramatically.
Thank you, Svetlana. And Princess, can you comment on South Africa?
So with our pilot sites, particularly Nelson Mandela, it is a metro, and there's quite a lot of movement. When you couple that with issues of unemployment, people moving around trying to find employment, we do experience challenges with loss to follow up. But we're using project-funded NGOs to constantly track the patients and link them back to care. And as our colleagues from the Ukraine has mentioned, it's not easy because wherever they go, they don't leave forwarding addresses. So it becomes a bit of a challenge, but we're doing our best with our community health workers to make sure that the patients are brought back to care.
Thank you. And I just want to say we're at the end of our webinar here. I would encourage people, once you have access to the slide deck, to go back and download the documents that you can use in your own settings to plan this type of activity. I want to thank so much our pilot teams in all of our countries. So in addition to Ukraine and South Africa, China, and Pakistan participated in this pilot. And we've heard from them on previous webinars about their experiences. I think it's a really rich learning experience for all of us. And I'm so grateful to all of you for sharing all of the advice and knowledge and experience you've gained. So thanks to everyone for participating. There's an evaluation poll up on your screen now, I think. And TB Care 2 will appreciate if you can just answer those few questions about the webinar so that they can continue to improve their service to everyone.
Yes.
Sharanya, I'm going to turn it back over to you to say goodbye.
Thank you, Lisa and Darcy, Princess, and Svetlana for leading such a great webinar. The webinar and the presentation is available, will be sent to all of your emails, and will also be available on our website, tb.academy. If you have any other questions, please feel free to email us at tbcare2webinars@urc-chs.com. But we will also be in touch sometime today with this presentation and a recording of the webinar. Thank you so much, everyone, for joining us today. Have a great rest of your day.
You too. Thank you.
Thank you.
Thank you very much.
Thanks all.
Bye, everyone.
Bye-bye.
Bye.